started?
Yes, I sure will, Candace. I just got the message about the recording.
Great.
And
Just started recording.
okay. Folks, welcome. This is John Barry with the Office of Community Living, and there's a number of other staff here who I'm sure will be introduced to you. And we are here for the Private Duty Nursing Rule Review Workgroup, the third stakeholder engagement meeting. And we are recording the meeting, and with that, I will give our usual suggestion or request, which is that you be very, very careful about information that you share about yourself, your loved one, recipients that would identify them as a Medicaid recipient, protected health information, personally identifying information. So please be very careful about that. I will be doing the usual speakers queue thing where I will call on people, and you in the Google Meet platform will be able to raise your hand. At certain points, I'll ask for names for the speakers queue. You can click on the hand icon on the bottom. If you are phone only, which it looks like we have only one person, but you can always unmute your phone by pressing *6 to give me your name at that moment. And then to speak, you would press *6 or turn on your computer audio if you're using that to speak. And depending on how we're doing the time, I will implement a 2-minute time limit per comment, just so that we hear from everybody and have time to go over what we need to go over today. You can also use the chat box to enter questions or comments or suggestions to us. And we do have on the screen now an email address for further comments or questions, also for the place on our website where the webinar recording will be posted. And again, asking people to, when you're not speaking, if you have unmuted yourself, to please mute yourself again so that background noise doesn't stop the meeting. I will stop there and ask, as usual, Candace and Aaron, if I've missed anything, which I sometimes do.
No, I don't think so, John. I appreciate it. And with that, I'll go ahead and kick us off, if that's all right, John.
Yes, you bet.
Perfect. Perfect. All right. Thank you so much for that introduction, John, and a little overview of kind of how the flow and the structure of the meeting works. It's super helpful for us to start out that way. I'll give an introduction around this meeting and an overview of which HCPF staff are on the call as well, and then we'll get right into the meat of the discussion. So welcome. Today is June 29th. Happy almost new fiscal year, as we do in state government. We celebrate multiple New Years. I don't know about the rest of you if you were as surprised as I was recently finding out that turns out July is this weekend. I don't know what happened in June, but apparently it happened. So we are almost into July, which is super exciting. My name is Candace Bailey, and I am the HCPF Division Director, and I am here talking to you all so that we can work on our private duty nursing rules and get those updated together. Next slide, please. So here's the purpose of our meetings. We are really here to engage and to discuss and collaborate about our rules so that you all can advise us on what works, what doesn't work, where we need to make some adjustments, where we need to make some changes, and so that we could put forward a really good, clear rule packet to the Medical Services Board towards the end of this year. Next slide, please. Here's our agenda. So we'll do I'll just do a high-level introduction of folks because we have a lot of folks online helping out. I require a lot of support. I need a lot of help sometimes in my life. So there are a lot of folks here helping me, so I'll do a high-level overview of who's here. Erin put in an attendance form in the chat. She'll repost that probably a couple more times just as people join late so that everybody has access to it. If you could fill that out so that we know who all attended, that would be really amazing. We'll go through some guidelines, and then we'll get into the meat of today's discussion around the rules. So if you recall, if you've been at any of the other ones, we are breaking out the rules in different sections. And so today we will be discussing a specific section, and we'll go through that discussion, and then we'll go into our next steps. So real quick, just as a high-level overview for HCPF staff that we have, before I go into housekeeping, we have myself, a member of my team who manages not only the private duty nursing benefit, but a lot of the home and community-based services benefits as well. So Erin Thatcher, who is the Participant-Directed Programs Unit Supervisor. It's a mouthful, in case you're wondering. So she is here with her fearless team, helping with making sure we take notes, making sure we have links posted, making sure the slides are moving, all of those good things. We also have our clinical staff here. Charlotte Christ is actually our office director who has joined us and will be here from a clinical perspective. And then we have a number of other folks that are on listening in to understand kind of the structure of stakeholder engagement. So we have some folks that are just kind of auditing the meeting, if you will. And then a lot of lovely stakeholders. And we are so grateful each of you are here. Next slide, please. All right, let's go through some real quick housekeeping, everybody's favorite process. Please make sure to mute when you're not speaking. Background noise is really hard to speak over. It's also really hard for other folks to hear when there's some background noise. Raise your hand and unmute when you have questions. John went through a lot of that around the chat box. Chat box is really helpful. We do our best to answer questions throughout the meeting. However, you all often have a lot of questions, which is amazing. And so we don't always have time to get to all of them, but we do get to all of them later and we post all of those online. Please, 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 as John mentioned, do not disclose any public protected health information, otherwise known as PHI. If PHI is discussed, we cannot post this meeting. We cannot post this recording, which would be really, really unfortunate for those that are unable to make it. Again, we'll do our best to answer your questions. Some of them actually we need to take back and have discussions. And so we will be sure to do that. Looks like our chat box is not quite, it should be, the chat box is available. I guess it's not easy to find. It is in the bottom right-hand corner. It's kind of the what is that word I'm looking for? It's the little quote box, the little speech bubble. It's on the bottom right. It's the second one from the far right. So if you do have a comment, you can click on that and you can type that in. And that's where all of our links are going through as well. All right. And again, there's some contact information for folks to reach out. Next slide, please. So here is our process. This is, we are presenting this at each of our meetings. So we began our revision meetings back in February, discussing various sections of the rule. We're going to continue these meetings into the late fall, hoping to have things wrapped up by the winter so that we can then present to the Medical Services Board with an effective date of early of 2024. Next slide, please. Okay, so here are our goals, really. We want to conduct a thorough review and update, the private duty nursing regulations by spring in collaboration with you all. We are hoping to revise the language that's unclear, outdated, really, hone in on things that need to be rephrased, removed, all that kind of stuff. Next slide, please. And I'm flying through these original slides. Most of them are repeats so that we have time to get into the meat of our meeting today. So here is an overview of how the rules are structured. So as you can see, it's numbered from 1 through 8. These are the various sections. Today, we are going to be discussing number 6, which is provider requirements. Next slide, please. Oh, looks like there is a question.
Yes, hi, this is Katie Waller. I just wanted to let you know, Candace, that, the chat is back. I'm sorry. For a while, we couldn't write, but now we can. We see errands, but for a while, it wouldn't let us write in, and now we can. So I put my hand down, and I apologize. Yeah.
No, I appreciate it. I think you raised your hand probably made it work. So thanks for doing that.
You're very welcome.
Perfect. Okay, I'm glad it's working now. So that's important. And it's something that we want to make sure we get done early in the meeting. So all right, the next here is an overview, again, of the rules. Like I mentioned earlier, in February is when we started this discussion, breaking it out by section. We started with prior authorization procedures, where we focused on the documentation requirements. And then in April, we focused on the remaining PAR components, which included a description of the PAR submission process, the third-party utilization management contractor utilization process, and then we also reviewed reimbursement. My apologies for not updating that tense there. And then here today, we are discussing provider requirements. This is focusing on the provider agency responsibilities when providing private duty nursing services. Next slide, please. All right, so some general considerations. These are important to go through each meeting. I almost said each month, probably each month for me as well, but we don't meet every month. That the language and the concepts that we are discussing are not final. These are just ideas. These are suggestions. This is a draft that we are putting forward. So please keep in mind that anything that you see as a suggested revision is not final, and we are bringing it to you to understand and see what you think of the suggestions. We are documenting all of the feedback and all of the ideas. We have a listening log that is posted that is incredibly extensive because you all have so many amazing ideas and thoughts and feedback. So all of that is being documented and is posted publicly for everybody to see. A couple of other things that are really important. There's going to be a few words that are going to be changed throughout. So we are adjusting the use of the word client to member. That'll just automatically be changed throughout. In some areas, we're just proposing to reorganize. So where things don't necessarily flow or fit, we're suggesting to kind of just reorganize for better flow and structure going forward. Excuse me. And we're going to add definitions for common terms. We're looking to spell out acronyms, really just trying to make these rules easier to read and much more clear for everybody. And again, we appreciate your amazing contributions. All right, next slide, please. Okay, so here is something that I think is really important that is new this month, is just kind of going through some of the topics and things that we have talked about that we are still working on. They're still under review, consideration. We still have conversations that we need to have with you all. So I know that there's a lot of these things are concerning and you all want some of them, but we are... well, I wanted you to know that they hadn't fallen off our radar, that these are things that we are going to talk about. These are things that we are still looking into. We're still doing research on. And so as they come up, you will see that they are on this list. This list is pretty extensive, obviously. But, you know, a lot of the things are around timelines, specific language, how to transfer a PAR, and definitions, expiration dates. So a lot around timelines. And then another big one that we discussed a lot last time was around the group ratios and how do we ensure appropriate limits around that without overdoing it. And so, and that's a difficult one, but it's something that we think is important. We want to have that conversation with you all. Next slide, please. All right, let's do it. Before we get started on the meat of today's meeting, which is provider requirements, I would like to, John, see if anybody has any questions around the structure or any of the information that is currently posted on the website.
Okay, great. Candace, thank you. Excuse me. So folks, if you do have a question or comment, as Candace just mentioned, you can raise your hand in the webinar. It's a little hand icon button at the bottom of the screen. That ideally would be, if you could use that, we'd appreciate it. If that doesn't work for you, you can type your name in the chat. For example, I would type in John for the Q. You can use the letter Q as an acronym for that. Anybody have a comment or question at this point? Okay. Hearing and seeing.
None. All right, well, let's move on. So let's talk about provider requirements. So suggested revisions are going to be removing outdated language and reorganizing the provider requirements into 6 distinct sections. It'll be a lot easier to read. It's a lot more clear that way. So here are the proposed sections, and you can go to the next slide, please. One of the things that, as part of the feedback actually, and some of the lessons that we've learned from our previous meetings, is we really want to make sure it's clear and understandable what we're proposing, whether we're proposing new language, we're proposing moving it, or we're proposing deleting it altogether. And so a new thing that we are trying this time around is having things either underlined, highlighted, or with red lettering, so it is clear in each of these slides. And also this is how we put it forward in the actual rules that are posted as well, what the actual change is to that language. So underlined means it's new language. Highlighted means it's just been renumbered or reorganized. So the language stays, but it's moving to a different section. And red lettering means that we are suggesting removing that language altogether. So just a note for that. And our next slide, please. Okay, so the first one that we're that we have here for you is the following two sections. So it's A and B, so 6.A, 6.B. I don't think you need me to read off all of those numbers. They were added to directly align with our long-term home health provider requirements, which are in 8.5 to 0.3. So here's the new section. As you can see, this is all brand new language, and really it is stating that these agencies have to also be Medicare certified and that they comply with all of the requirements with our sister agency, CDPHE, and then DORA and all of the other agencies that they have requirements. It just puts it in our regulations as well. Next slide, please. All right, here is one of the proposed new sections. And so with this one, what we're looking at is breaking out more along lines of what a home health agency must do. And so again, this is all brand new language that you all can see about discontinuation, not, how they can cease operations, how they can't, who they need to notify, how much time is required. I don't want to read through this entire slide because that is incredibly boring, and I would like for you all to stay awake because I enjoy your company very much. And so I'll let you guys kind of browse through that. Again, all of this is posted online. It was posted before today's meeting, so you all can have a chance to take a look at it. And again, this is not the only opportunity to provide feedback. John, it looks like Katie has some feedback.
Yes, Katie, go ahead, please.
Thank you. I just had a couple questions about the new number 4, which is about home health agency not discontinuing or refusing services.
Yes.
And the two questions I had was, how does this section apply when a member has been terminated from PDN services? And is it requiring the home health agency to do something in addition to what they're already required? And then the second piece was just more broadly, what does documented efforts mean, and to whom do they have to show that, right? Do they have to show that to the member? Do they have to show it to HCPF? Like, I just wasn't clear on that.
Right. So this is specific to if an agency plans to discontinue services to an existing PDN member. So this is not if the member is no longer eligible for PDN services. This has to do specifically with that agency is no longer able to serve that member for whatever reason. And so that's what that is specific to. And then as far as what does documented efforts look like? I mean, that varies. And so that's why we haven't specified it, because there are a lot of different ways that an agency can document it, and it has to be available upon request. So whether we ask for it or the Department of Public Health and Environment, CDPHE, asks for it from a survey, whoever needs to see that information, the agency must have it on file and be able to produce it upon request.
And is that written somewhere in the rules? Because it's not in this section. Like when it says documented efforts must be made available upon request, that's not in this part. Is that somewhere else?
That is, and I don't have all these different sections memorized. That is a good question, and let me confirm, because if it's not, I think that's probably a miss in an area that we need to add. I think that's a good point, Katie.
Thanks.
Yeah, thank you. And yeah, John, it looks like we have a lot of questions coming in right now, which is great. And I think because we flew through those first few slides, I think we have time to go ahead and take some of those.
Sure. I'm not sure in terms of the chat what came first. So folks, I'm going to start with the hands that are raised in the webinar, and then we'll move to that perhaps. Heather Alvarez, please go ahead. I'm asking people to keep it within 2 minutes. Thank you, Heather.
Are you able to hear me okay?
Yes, we can. Thank you.
Okay. What about instances where discharge is related to, safety concerns that we have for our nurses in the home or staff in the home?
Yeah, so I want to say the same requirements would apply, obviously, because what we can't do is we can't put their safety at risk, right? And so how do we address that? I think that's where you come into the documented efforts. And typically a safety concern from my experience when it comes to staff is not, there's something leading up to it. And so it's not out of the blue, nowhere, and you have to terminate. There may be extenuating circumstances where things happen, and maybe.
Yeah, that's more what I'm thinking of. I mean, we had an instance a few weeks ago where a family member sexually assaulted our staff just out of the blue. And that's like that would be an immediate discharge, and we wouldn't send staff back to that environment.
Okay. And I see that Alex suggested some language. Alex, it looks like it got cut off, about aligning this with what we have with the home health regulations. I'm just seeing if there's anything about safety in here. I don't see anything around the safety of the staff. Erin, did you want to chime in?
Sure. Good morning, everybody. I think the
there it is. There's the exception for safety. Sorry.
Oh, no worries. So the intent here is really to try to streamline the current regulations. Thank you for feedback on this. I will say we do want to make sure we're in alignment with Chapter 26, which is the Department of Public Health and Environment's regulations for home care agencies. So we'll take a look at that again. Thank you.
Thanks, Erin. And thank you, Alex, for getting the rest of it. Google Chat is lovely and only lets you post so much at one time. And so I like that number 5 in there where it says exceptions will be made to the requirement for 30 days advance notice when the provider has documented that there is immediate danger to the client, which would be member, home health agency, et cetera, et cetera. Do you think, Heather, that to me reads like that would meet that need?
Yes,
okay.
Absolutely.
Okay, that's super helpful. We'll take a look at that and see. Obviously, to Erin's point, we want to make sure we're in alignment with Chapter 26, but everybody's safety is important, including staff member safety. And so we want to make sure that we have those exceptions where we need them. That's great.
Thank you. So next we have Erica. Erica, thank you. You have 2 minutes.
Hi, thanks, Candace. Can you hear me?
I can.
Hi. Thank you so much for these. And just along the same lines of the comments that Katie made with regard to the documented efforts, I would have the same question about the notice of at least 30 days to the member or the member's legal guardian. Just a little bit more clarity around that, like what the notice looks like. And I know we have a lot of, different notice requirements around PDN with, PARs and things like that. And so just like a little bit more clarity around the notice would be helpful, I think, of what that means, what that looks like. Is it snail mail? Is it an email? Is it, word of mouth? Like, what does that notice mean?
Okay, that's helpful. Okay, that's helpful suggestion. Thank you for that. We will definitely take that back and see what kind of maybe additional clarity we can add to that section. That's great.
Candace, looks like that's all we have for now for the queue.
Well, let's move on to the next slide. Okay, so this section, this is how it is currently written, just so you know, and we are proposing moving it to Part C. So this is kind of Part 1 of this section that we're proposing to move. So if we can go to the next slide. So this is the suggested move of this. The highlighted areas, as you can see, all the lettering and things like that, it actually provides, it's a little bit easier to read when it's lettered or numbered like that. And so the formatting just makes it simpler to follow. And so those have changed just from the lettering standpoint and the formatting standpoint. And then the red, we are suggesting to remove this red language. As you all can see, one of the suggested, thank you, Erin. One of the suggested changes is removing the word that the individual, that the licensed nurse has education experience to provide care to technology dependent, but instead changing that to high acuity medically complex persons. I think that really will better capture the larger population because, as we all know, it is not a requirement for children to have technology dependence. Often they do, but it is not a requirement. They have to have the requirement for the continuous need of the services. And so I think replacing that language will help with clarifying that. And also it just provides a broader, bigger picture for our nurses and what would be helpful for them to be trained in. Um, okay, next slide, please. We'll go on to the next one. We'll do like 2 more and then we'll pause for questions. Okay, so here's another one that is currently part of 6.A that will be moving to 6.C. As you can see, there's those red areas are being suggested to be removed because they would be duplicative. You can go to the next slide, please. This is kind of the new format for this this part of 6.C, because there's multiple parts, obviously, because this is 2 and 3, as you can see. And then, you know, just the formatting is a little different. And then there are a couple of additional words. So switching out member client, obviously, and then adding in authorized provider versus just physician. Okay, let's go to the next slide, please. Okay, and so this is another part of 6.A that will be moving to 6.C. This is currently how it's written. And the next slide, please. And this is what it will look like. So again, here's some new language. Home health agency policies and procedures and professional standards of practice to monitor safety and quality of home care. That's some language we are proposing to add. Suggesting adding in that care plans are no older than 60 days. So it's clear what the care plans as far as the timeline should look like for that. And then obviously replacing single entry point or other case managers with case management agency, as we will no longer have single entry points here very soon, because we're moving just to case management agencies. So those just a couple of minor changes there. Before we move on, John, do we have any questions?
Thank you. So folks, if you have a comment or question, please raise your hand in the webinar. And while people are doing that, Candace, meanwhile, looked like there was a comment from Erica at 10:28.
Great. So it looks like Erica is pointing out that in 4, it states 30 days, and then in the next number 5, it says 30 calendar days. And so we should probably clarify that. I appreciate you pointing that out. And so we will clarify that piece, Erica.
Thank you.
John? Oh, go ahead, Erica.
So sorry, I had one other question. And then just, I was wondering if we're using, is authorized provider meant to be, do we have that defined somewhere? I'm confused if the attending physician or authorized provider, just using that interchangeably, or if we define that anywhere.
That is a good question. We should have a definition for authorized provider if we don't have one. And the idea was a lot of times we know a lot of individuals don't just receive their care from a physician. There may be, you know, a nurse practitioner. There's a lot of different medical professionals that could be providing care. Erin, did you want to jump in on that one?
Sure thing. So we will get to a little bit more about that in a little bit further down in the presentation. So thank you.
Oh, okay, thank you.
Thank you, Erin, and thank you, Erica.
Okay, thanks. Katie, you're up next. You have 2 minutes. Thank you.
Thank you. Let's see, I had just a couple questions. One was, I think there's maybe 2 or 3 parts in this section that refer to home health agency policy.
Mm-hmm.
And I was just curious about what that is. How do members, the public and advocates understand what that is? And, you know, is there a rule or requirement that is shared with the members and that is public? And so that I can get it, for example, if I'm representing someone in a hearing where the home health agency is saying, this is my policy. So I was curious about that. And then I had just a couple other questions about things that were removed and where they might be.
Okay. So first and foremost, let's start with, and I was just looking up in some of the other slides here to see about that. So our agencies are required to have policies and procedures, as pretty much any business does. And so this is referencing that this particular component, so on-site visits, must be in accordance with their documented policies and procedures. I'm not sure if we have earlier, I'm just looking at this one. This one's talking about rules. I'm not sure that we have in there around the availability of their policies and procedures. We always require agencies to make their policies and procedures available to us. It's something that CDPHE, Department of Public Health and Environment, actually reviews when they do surveys. But if we don't have that specific piece in there, we can look at adding that.
Okay, thank
Okay.
you.
Oh, John, I think she had
Thank
just like one or two more really quick.
Oh,
I do,
sorry.
yeah.
Okay.
No worries.
Sorry. I was just curious about some of the things that were removed and just making sure that the rules make clear who's responsible. So,
Sure.
like one part that was removed was submitting the PDN application to the URC and doing it on time before the previous part expires. Who is ultimately responsible for that, and where is that in the rule since it was removed? And then similarly, there was a section removed about kind of cultural competency in terms of employing staff that have training regard to a client's demographic group. And so I just wanted to ask about where those ended up if they're not here anymore.
Yeah, so the submission of PARs is later on. So, and it was removed from that particular section because it was duplicative. And so that is a little bit further down. As far as the cultural competency, the training, that I believe is in another section further down as well. Aaron can correct me if I'm wrong, but we can confirm that as well. So a lot of those, because I asked those same questions of, well, what are we still doing this? And the answer is yes. It's just it was duplicative language, and it is addressed in a little bit more broad terms at times further down in the rule. Thanks, Katie.
Okay, thank you. Candace, we have Jennifer has her hand raised, and then after that, Alex has a question in the chat. Jennifer, please go ahead. You have 2 minutes. Thank you.
Hi, I'm just wondering, I don't know if it's further along in the slides as well, but kind of going back a couple of slides, it talks about changing the language from technology dependent to high acuity.
Mm-hmm.
Is high acuity actually defined somewhere as well?
That is a good question. I actually don't think we have high acuity medically complex persons defined. I would love to, what I'd like to do is I'd like to actually chat with our clinical staff because in all the conversations I've had with our clinical staff, that's a pretty common clinical term. And so maybe if we do need to define that, we can look at doing that in the future.
Thank you. Yeah, I think that'd be great because I think that's subjective language for sure.
Okay. Thank you for that feedback.
Thank you.
Candace, and then we had a question from Alex in the chat.
All right. Alex's question is, what HCPF regulation requires agencies to make policies available to HCPF and CDPHE upon survey? Alex, I do not have that regulation memorized off the top of my head, but we can certainly, this will all be posted in our listening log, and so we will post that regulation there and where it is. Erin has her hand raised. Erin might have these regulations memorized, though.
Well, I'll just say thank you for assuming that I might, but I don't. So Alex, so right now how the rules are kind of organized, each section and like waivers or other services usually have a requirement in each section. So we will go through and make sure that it's consistent. There are some other big rule changes happening right now. So I'll put that on our to-do list. Thank you.
Thanks, Erin. Great. John, any other questions right now?
Candace, no, not for right now. Looks like that's all we have.
Excellent. All right, let's move on to our next slide. Okay, so this section currently is written, which I believe will be moving. Though I don't have it listed here. My apologies for that. So this section is how it is currently written, and we'll go to the next slide. And these are the proposed changes. So as you can see, the formatting is being proposed to be changed. And then adding kind of a header of the home health agency must inform the member and their family in-home caregiver of the following responsibilities and ensure that the caregiver is able to do these things. And so most of these were already in there. Actually, all of these were already in there. They have just been moved to this section. and reformatted just so that it's a list and it's a little bit easier to read. And then obviously client being updated to member. All right, this is how this current section A12 is written, and it will be adjusted to, next slide please, to look like this. Again, a little bit easier to read, making it clear, putting a title that this is environmental requirements, which is helpful. So when you're looking for specific things, it's nice to have headers for the different sections so you know which section to look at. And so again, this is another one of changing this to a list format because it's a little bit easier to follow. The home health agency has to do an in-home assessment and document the following safety requirements. Okay, next slide, please. We are trucking along here pretty quick. This is how this current section is written. And again, it will be moving to, next slide. It will be moving to this format. So as you can see, it's again, it's a new number. So it's 6F, and then it has a header of the physician / authorized provider role. And in here is where we talk about their role and kind of what we need out of the physician / authorized provider. All right, let's pause there and take questions for today, or for this section, sorry, for these last few sections. I went through a few.
Okay, thanks, Candace. So folks, yes, if you have a question or comment, you can raise your hand in the webinar, the little hand button at the bottom of the screen. You can type your question or comment in the chat. So while I'm looking for hands in the webinar, Candace, we do have a question in the chat from Christine.
All right. Oh, it looks like we had one just before that. From Myra, can you clarify if the working telephone can be a cell phone versus a landline? We can certainly look into providing that clarification language in there. And then the next question from Christine is, can you clarify if the backup power supply is mandatory? We would have to check on Chapter 26 regulations and also the regulations from the Centers for Medicare and Medicaid Services and what the Medicare requirements are. But I do believe that if there is any sort of technology that is operating, there is a requirement to have a backup power supply. Because if that power were to fail, yeah, you need a way to maintain that life-sustaining power or equipment. So we can clarify that as well.
Okay, thanks, Candace. So we have a couple hands raised then. Katie, please go ahead. You have 2 minutes. Thank you.
Thank you. I just had a quick question just about the language for this section.
Sure.
Because it says that this is the physician or authorized provider role, but then the first sentence is that it sort of seems to put the requirement on the home health agency to coordinate, if that makes sense. So the first sentence is the home health agency shall coordinate with the physician. And then if you go to 5, it's saying the home health agency shall coordinate with the physician to communicate with the home health agency. And I guess I'm asking, do you understand what I'm saying? It's sort of circular. So it's unclear to me when I read this, whose responsibility it is. Is it that the home health agency needs to coordinate with the physician to communicate with themselves? Do you understand my question? Like, it's, even though this says it's the physician authorized provider role, it's saying the home health agency is required to do these things with the physician.
Yeah, so the home health agency is required to do these things with the physician. And so part of this is help, and we can reword number 5, maybe that would make it a little bit more clear. But number 5 is, and what we want to make clear is that there has to be an open line of communication between the attending physician or authorized provider and the home health agency. It is not, we need that information coming from the attending physician. They have to be involved in the care. They have to be providing those medical necessity documents. They have to be providing the need for the medical care. And we need the home health agencies to be able to have the ability to tell the physician, we have to get this information from you. In order for us to be able to serve this member, you have to be communicative with us. We have to have this open line of communication. And that is what we were attempting here. And again, if we need to adjust some of the language so that's a little bit more clear, we are happy to do so. But really, this is meant to help support the home health agencies with, because a lot of times we know that the physicians are not always responsive. And that is a key component and something that these home health agencies have to have. And if one end of them is not holding up the bargain, that's a problem. This is individuals' health and safety. And so we have to make sure that we're providing that information.
That makes sense. And I appreciate that. And it sounds like this section is to empower the home health agencies to be able to say, these are your requirements. And I'm just not quite sure the language does that the way it's written now. So maybe we can take a look at that.
Sure. Thanks.
Candace, we had Steve, I believe, from CDHS, CDPHE, had his hand raised, but perhaps not now. So Steve, if that was a mistake, you can go ahead. If not, we'll move on.
No, I was just going to say, I'm looking through the rules now through chapter 26 for emergency power, and they have to have a plan in place. It's not very specific to any type of backup power.
Okay. Thank you, Steve. That's helpful. Thanks for looking at that.
And I'll keep looking to make sure that I've got that correct, but I don't see anything specific to that.
Okay. Thank you.
Candace, there are a number of comments, questions in the chat about this issue, I believe, but at the bottom there is one from Jennifer that seems to be a different question.
Okay. Well, let's start up with Pam, just so that we can kind of go in order. It helps me stay focused, if you don't mind. So Pam is asking how we define backup power. And as Aaron put in, that the adequate electrical power, including a backup power system, is what is currently there. I hesitate to define that too broadly as one. There's a lot of things that are shifting and changing right now as far as technology and medical technology. And I don't want to limit ourselves to anything, but we want to make sure that it's clear that backup power is really important, especially for those that are on life-sustaining technology. And the weather is not getting easier. We all know things are getting much more extreme. And so I think we need to be prepared for more extreme scenarios. So we can take a look at that. I do know, I hear you, Pam, that generators are expensive. We actually have a number of projects right now, actually through ARPA, around backup power supplies, generators, and how we can get those for individuals. And then there's also, outside of that time frame, additional projects and grants and things like that that are ongoing continuously. But we can continue to look into this language and this wording to make sure that everybody is comfortable with it going forward. All right, the next comment I see here is that agreeing with Pam that it's worded as though the agency is required to provide the backup power source. Okay, we can take a look at that. And again, we want to make sure we're in alignment with Chapter 26 regulations. And so we will take a look at that and make sure we can provide some clarity there. Looks like Christy was mentioning a program about purchasing backup generators. Thank you, Christy. And Pam sent a link. You guys are wonderful. Thank you for sharing this information. And then the last question here on the chat is Jennifer asks, can language be added to clarify, to clearly define medically stable? So Charlotte, do you want to chime in? Because I believe that medically stable is a pretty, I would be interested, is that a normal clinical term? And is there language that we would want to add, or do we need to take that back and dig in a little bit further?
Yeah, I do think we need to take it back, and it's a great question, and we should try and add some sort of recommendation, but
Okay.
you know, clearly it has to do with you know, that member or patient being in a state of health for which, you know, a constant oversight or the PDN requested, you know, bedside oversight is not necessarily required or anticipated, you know, so changes in condition, severe changes are not foreseen or expected that would cause that member to need that bedside care. I do think it's worth trying to put some sort of explanation or definition around that to be more clear.
Great. Thank you so much, Charlotte. Thank you for the question, Jennifer. And I see Heather added in that they evaluated the patient as appropriate for home care more than stable. Okay, that's an interesting perspective. You know, when I read that, I think of, is the individual able to be at home versus in a hospital? But I hear your differences there around home care versus stable, because not everybody, a lot of individuals' health fluctuates when you're talking about oxygen levels and a number of those things. And so we can certainly take that back and take a look at it.
Mm-hmm.
So thank you for those points. Other comments or questions?
And this looks like we might be at the end of the speakers queue for now.
All right. Well, hey, everybody, I have really great news. That's actually the end of our slides for the meat of the changes. I thought we had a lot more, and it was just because the team did such an amazing job of putting it together of a before and after so that everybody could see. As you can tell, this section isn't quite as in-depth, but there are some really great clarifying changes that we are hoping to make here. Can we go to the next slide? All right, so future engagement opportunities and meetings. We are going to have additional meetings where we will continue to go through the sections. I believe we have 1 or 2 sections left to go through. And so our next meeting, so this is June, our next meeting will be in August. Probably all the kids will be back in school by then, which will also blow my mind. And just prepare you now. It will surprise me when August comes that my kids are back in school. So we will go through those. So those will be the next opportunities. Again, we had discussed, and we will bring back the changes that we are proposing and the changes that we kind of agreed upon. We're going to come back at the end once we have a chance to go through all the sections and bring back the changes so that we can all take a look at them again one more time before we bring it to the Medical Services Board. All of our documents and our recordings are available on our webpage. Christy, I don't have the August date off the top of my head. I can look. But thank you, Brooke, for putting that in there. So there's our private duty nursing webpage. Somebody will post that in the chat for us, I'm sure. There's a variety of ways that you can submit, and thank you, Erin, submit feedback. We have a Google form where you can submit feedback. You can send an email to our homehealth@state.co.us with the subject PDN rule comments. You can call us and leave a message. All of those things, all of those pieces of feedback, any way that you choose to provide us feedback, all of that goes onto our listening logs. So if you submit feedback, it will be posted so other people can see what feedback you suggested and our response to the suggested feedback. Again, that is all posted online so that everybody has a chance. Thank you, Erin, for posting the date. The next date for the next meeting is August 31st, which feels like a long ways away, but we all know it's not. And there is the feedback form and the email address. Thank you so much. And then Brooke put in the member emergency preparedness grant application for backup power supplies, which is awesome. Thank you so much, Brooke. Next slide, please. Again, here's the various ways that you can provide feedback. You can also fax us. And does anybody have a fax machine anymore? Do those exist? I'm not sure. It's been a very long time since I called a number and I got that screaming, like high-pitched sound in my ear. I'm very thankful for that. We all know what I'm talking about. And you can even send us a letter. I don't get mail very often, so if you want to send us a letter, that would be amazing as well. And next slide, please. Questions. So another opportunity, last minute questions. I realize that we flew through that. Happy to go back to any of the slides if you want to kind of rehash any of the items. But I realize also I don't want to waste your time, and we are ending super early, which is usually exciting. Any questions before we end?
So folks, if you do, you can raise your hand in the webinar as before, or type your name in the chat. Looking to see if we have, while I'm looking, I'll just mention that August 31 meeting is on our online calendar and the link is in the chat.
Thank you, John.
Seeing nothing right now. Candace?
All right. All right, well, let's move forward. There's our contact information on the next slide, please. Sorry. So home health inbox. This is really the best way to get in touch with us if you have rural feedback you want to provide. If you have a question about services, if you have a question, I mean, this is your one-stop shop for getting in touch with us. There are multiple people that are on this inbox. I think that there's like 6 of us that actually, every time an email comes into this inbox, we are copied on it. So I see every email that goes into this inbox, as does Aaron, as does Christine, as does Paul. Like Cassie does it. Like there's a lot of us that see it, which is wonderful. And it provides us an opportunity to make sure that it is getting answered if any of us are out of the office for any reason. So please, please, please utilize this inbox if you have questions, again, about the benefit, about the services, about PARs, whatever. Use this inbox so that we can make sure that we get your questions answered. And with that, I thank you all. Thank you so much for your time. The meeting is August 31st from 10 to 11:30, or apparently, if I'm running the slides, 10 to 10:54, as according to my clock. But I thank you all so much for joining today. I really appreciate your feedback. This is critical information. Your feedback is really important to us, and I look forward to seeing you again in August. Thank you, everybody. Take care. Bye-bye.